at the sternoclavicular joint. Starting medially at the SC joint, you can come across the clavicle, feeling for any bony abnormalities. You can move superiorly into the supraclavicular notch, again feeling for swelling or masses in the inferior clavicular notch as well. If you stay in the inferior clavicular notch, eventually you're going to feel a bony prominence. This may be tender with pathology at the shoulder as well. You can continue to move laterally as well, and again, as you get to the shoulder, that first bony prominence is going to be the lesser tubercle of the shoulder. You'll then feel kind of a thick guitar string type mass. That's the long head of the biceps. Farther laterally is the greater tuberosity of the shoulder. If you go superiorly, at the very end of the clavicle, you get where the clavicle articulates with the acromion, and that's the AC joint. You can then walk across the acromion on the bony prominence, and you're on the spine of the scapula. You tuck the elbows in at the side. They're going to push out against you. Go ahead and push out. And you provide resistance there, again looking for weakness or pain. Some people will like to kind of preload them either into a little bit of internal rotation or a little bit of external rotation to try to take deltoid out of the picture so that they're entirely doing infraspinatus in that position. The next one will be teres minor, and so they're going to come up again into that plane of scaption with the elbows at 90 degrees. And again, you can test individually or bilaterally, but you're going to resist external rotation now in this position, so go ahead and push your hand against mine. And relax, again looking for pain or weakness. And then the last one is going to be the belly
rotator cuff tear. The next tests I'm going to go over are external lag tests for the shoulder and for the rotator cuff. Now I'm going to position my patient in about 90 degrees of abduction, and I'm going to bring her elbow to about 90 degrees and externally rotate her. I'm going to bring her back into a little bit more external rotation, and then I'm going to let go, and I'm going to see if she's able to maintain that external rotation. And so my patient has a negative external lag test here. If it were a positive test, her arm would end up falling a little bit more into internal rotation because that muscle, that tendon of the rotator cuff complex would not be intact to keep her into that external rotation. So if we're falling into internal rotation, or if that arm is falling down to our side, we're concerned about a tear of the rotator cuff muscles or significant tendinopathy of the rotator cuff. Another version of this would be going into external rotation without going into abduction. So I can passively externally rotate my patient, and typically I will compare to her contralateral side, and I will let go. And I will see if my patient is able to maintain that external rotation, or if it's a positive test, is she going to fall into a little bit of internal rotation. Now you can compare this to the contralateral side as well, but for demonstration purposes, I'm just using her one side. Test. I'm going to have my patient go into full forward flexion right here, stop at about 90 degrees with an open palm. I'm going to apply a downward force here, and my patient is going to resist me. What I'm looking for here is pain, and in particular pain right along the area of that biceps tendon in its bicipital groove. So go ahead and relax. Next test we're going to go over is Yergason's test. Now I'm going to show you one way to do this with a variation on it. Yergason's test is a test where the examiner is going to resist the patient while the patient is trying to supinate. So we're going to demonstrate. I'm going to have my patient at 90 degrees at her elbow, and I'm going to pretend like I'm shaking her hand right here. I'm going to have her supinate almost as if she's doing a biceps curl, and I'm going to resist her. So go ahead and try to supinate. Good. And I'm resisting her at this point. What you're looking for is you're looking for pain right along that biceps tendon. Now there's a variant to this where I'm going to have my patient resist me, so she's going to try to supinate again. And I'm going to externally rotate her while I'm doing this. What I'm feeling for is not only whether or not the patient has pain at the long head of the biceps, but I'm also looking to see if she's having any subluxation of that tendon outside of that bicipital groove. That can also cause a patient a lot of pain in this anterior.
This one is done with bringing up the arm to about 90 degrees of flexion. You can bend the elbow, and then you're essentially just going to internally rotate in this position. You'll see some modifications where they'll kind of really crank on the arm or start to bring it across. But if you get into this position and really internally rotate them, you're going to be looking for pain kind of generally across the anterior shoulder. And this is, again, a special test for subacromial impingement. Our other subacromial impingement test is Neer's test, and this where you internally rotate at the shoulder and bring them up into frontal flexion, looking again for that general anterior shoulder pain as you get towards the end ranges of frontal flexion. Our last test is for AC joint pathology towards the superior aspect of the shoulder. You're going to bring them into frontal flexion to about 90 degrees, and then just adduct horizontally across the body. This is also somewhat called the scarf test, as the arm is making a scarf across the neck. It's important to note where their pain is in this position, because this can also be positive in cases of rotator cuff tendinopathy or subacromial impingement. So you want to note if their pain is occurring right at the AC joint, or if they're getting that anterior lateral or posterior lateral pain with some of the other conditions.
Follow this up with Job's relocation test. So what I'd like to do for this is I like to have my patient laying down supine with their shoulder nearly off the side of the table. I like this position because her scapula is nice and stabilized against the back part of the table. I get my patient into about 90 degrees abduction. I get her elbow into about 90 degrees of flexion, and I maximally externally rotate her, and I apply a little bit of pressure here. Now, what I'm looking for isn't exactly pain, although this could be a little bit uncomfortable for patients. What I'm looking for is for the patient to be apprehensive about this position. So patients who have ever had any shoulder dislocation or have had a shoulder subluxation incident in the past might feel quite apprehensive with this. If that is the case, what I'd like to do is I'd like to follow up that exam with Job's relocation test, where I apply my hand around that anterior capsule of the shoulder, reinforcing it so that when I bring them into external rotation, they don't have that same sensation of apprehension. So next we're going to go over O'Brien's test. O'Brien's test is classically supposed to test the labrum of the shoulder. However, a lot of times it's very tough to test just one part of the shoulder with a single test. It's better to use this test in combination with other tests to figure out the etiology of your patient's pain. So to run through O'Brien's test, I'm going to ask my patient to go ahead and get herself into forward flexion to 90 degrees. I'm going to have her line up her thumb with her nose, and I'm going to have her resist me as I apply a downward force. Excellent. That's part one of O'Brien's test. The second part is I'm going to have my patient rotate so that her thumb is pointing downward and with her hand still in line with her nose. And I'm going to again apply a downward force, and I'm going to have her resist me. Good. Go ahead and relax. A positive
that occurs on the toes of an individual's foot, known as a corn. There's two types of corns. There is a soft corn, which occurs in between the toes, which is 100% of the time caused by footwear that squeezes the toes. And what ends up happening is, if you look at the shape of the toe bones, they're hourglass shaped. So they're narrow in the middle and wide at the joint surface. So a corn is caused by one of the wide joint portions of one toe rubbing up against the wide joint portion of another toe. So that's typically known as a haloma molly or a soft corn. Very common location in between the fourth and fifth toes, because most people's shoes do that. Hard corn locations popular on the end outside part of a toe. Again, shoes squeezing it. They can become very painful. Traditional conventional therapy is to trim them off with scalpels and have the patient come back as often as they develop. Worse yet is to not educate the patient about the footwear, make an incision on the top of their foot, and take out bone or smooth bone. That's the traditional approach. Natural, preventive, conservative approach is to encourage the individual to not allow anything to cause the toes to rub against themselves, as is the case of a soft corn, and not to allow the shoe to rub on the outside part of the toe, known as a hard corn. Another very popular location for callus or corn tissue is on the inside of the big toe joint, because the abductor hallucis muscle is trying to pull the toe out, while simultaneously the shoe, the tapering toe box of the shoe, is trying to push the toe in. So corns can be cured almost 100% of the time by understanding that the toes are not meant to contact each other. They're meant to have appropriate spaces in between them. And if we allow for that, we can actually see corns go away.
I'm going to be palpating and looking at the skull shape first here. And then I'm going to palpate the skull for size and symmetry. Alright. I'm going to look at the face here, inspecting it. Alright, so I'm going to go ahead and do the first cranial nerve here, and that will be cranial nerve 7. I'm going to have you raise your eyebrows for me. Okay, puff out your cheeks. I'm going to go like this. Okay, smile and frown. close your eyes really tight and then don't let me open up your eyes. Your temporal pulse is here. Okay, they seem to be a 2 bilaterally. Since I'm here, I'm going to palpate for temperature across your face. Make sure we got the ears in there. Okay, and do you have any tenderness when I go like this?
No.
Okay. Alright, so we're going to go back to this, we're going to go to this TMJ joint here. I want you to clench down for me. I'm going to grade those. I want you to protrude your jaw out for me. Go back in for me. Go laterally side to side. Alright, and then clench your jaws together really hard. And don't let me pull it down. Good. So that was the trigeminal for the ears. I palpated it earlier for warmness. Does this hurt when I go like this?
No.
No. He's in and doing temperature here at the same time. I'm going to go underneath a little bit. And we'll just do all the temperature for the whole upper extremities. So we got all that taken care of. I don't see any edema or anything. I'm going to go ahead, I'm going to feel the radial pulses. I'm going to move this up a little, that's fine. So you can just relax. Just have to grade them. You don't have to count them. Okay, there are 2+, and I'm going to feel for the brachial. So I'm going to do, see if I can do it. On both sides. I'm going to feel the epitrochlear lymph nodes. Alright. And then I'm going to test for skin turgor. I'm going to do that on his hand on both sides. You could also do that up at the clavicle if you wanted to. The nails here. I'm doing caprifo at least on 1 digit per hand. You want to make sure you're looking at the profile of the nail. Move your vein, making sure you're noting that there's no clubbing. So we looked at the nail, we did the cap refill. So now we're going to do, you can kind of see me here. So let me inspect this hip. Alright, palpating. Alright, I want you to flex your hip up and extend it back down. Alright, that's good. You can put it back up here. And we're going to do the same thing, external rotation out, internal rotation in. Okay, good. And then flat, and then abduction, adduction over. Good. You can get, if you want to, center yourself back on the bed.
यहाँ यूं करके रखने किसी जगह इसको कोई आपको तकलीफ तो नहीं है ठीक यूं खोल के रखें ठीक रख दीजिए दोनों हाथ खुद से ऊपर उठाएं रख लें अब ये दोनों बाजू पर उठाएं पूरे जोर से, ठीक है। अपने दोनों बाजुओं को नीचे को जोर लगाएं, ठीक है। दोनों बाजुओं को बाहर को निकालें, ठीक है। अंदर को करें, ठीक है। दोनों बाजू यूं करें, सीधे ऊपर करें, ठीक। रख दीजिए, अपनी तरफ जोर लगाएं, जोर से, ठीक है। इसके साथ भी अपनी तरफ जोर लगाएं, ठीक है। बाहर को पुश करें, ठीक। मेरा उंगली दबाएं, इस हाथ से भी जोर से, ठीक है। अपने हाथ को यूं इकट्ठा कर लें, उंगलियां बाहर को खोलें, इस हाथ की उंगलियां बाहर को खोलें, ठीक है। ये कार्ड मेरे हाथ से आपने छुड़ाना है, ठीक। दूसरी उंगली से, ठीक है। इस तरह से इस हाथ से भी, ठीक। अपने अंगूठे को यूं कीजिए, दूसरे हाथ दूसरी उंगली के साथ, बारी बारी, इस हाथ से, ठीक। कोई चेंज बनाए, अपनी मुट्ठी से नीचे जोर लगाएं, मेरे हाथ में मुट्ठी को ऊपर को लेके जाएं, ठीक। मुट्ठी को नीचे को ऊपर लेके जाएं, ठीक। ऐसे रख दीजिए, ये उंगली को यूं करें, ढीला छोड़ दें, दीजिए। लगता महसूस होता है? क्या लगता है? ठीक। जब मैं लगाऊंगा तो आपने बताना है कि किस जगह पे लगा है, किस तरफ लगा है। आंखें बंद कर लें। क्या लगता है? चुभन हो रही है। हाँ, ठीक है। अब आपने आंखें बंद कर लेनी और बताना है कि किस जगह पे लगा है या चुभा है। ठीक, उल्टा करें। ऐसे कर लें। एक जैसा दोनों तरफ? तो फर्क है? अब
Right, Mr. Henry, I'd like to have a little look at your knee now to see what's causing your pain. And in order to have a really good look at the knee, it's best if we can take your trousers right off. Would that be okay?
Yes, that's okay.
Okay, do you want to go over to the couch?
Okay,
Okay, Mr. Henry, are you comfortable there?
I am.
Good. The first thing I'm going to do is have a little look at the muscles in your legs, okay? If I can get you to tense the muscles in your thighs on both sides. That's great, and relax. The next thing we're going to do is have a look for any swelling in the knee.
Okay.
That's fine, no evidence of any swelling. Then we're going to check and see if anything within the joint is tender for you. So if you could bend up your knee just slightly for me, and I'd like you to let me know if any of this is uncomfortable for you. That's all okay? Good. Okay, rest it down there for me. The next thing is we're going to look and see how your knees are moving. We're going to check both sides, and we'll start with the side that hasn't been bothering you so much.
Okay.
If you bend up for me, all the way up, and then down, and then on this side, all the way up, and down again. That's great, they both seem to be moving fine. Well, next we'll check the ligaments, and we'll start with the ligaments on the outside of your knee. So if we can just bend up slightly again for me. Okay, and then bend it a little more, and we're going to check the ligaments that cross over inside the joint. And they're fine, okay? Okay, lastly, we're going to have a little look at the lining of the joint or the cartilage, okay?
Okay.
And bend up again for me. Good, that seems fine. Okay, that's all done. Looking at your knee, I can't see any evidence of any major problem going on within the joint. There's no swelling or tenderness, your knee's moving really nicely, and all the ligaments and cartilages are okay. What I think's going on here is something called anterior knee pain, which is very common in young fit people who go running like you, okay? What I think we should do is get you to pop your trousers back on, and then maybe we should have a chat and see how we can help you. Is that
Okay.
all right?
Yeah, thank you.
Good.
It's really amazing that you're so focused and enjoy the class. This seems like it really helped your grades for this certain topic.
Yeah, I suppose so.
It seems like you're really motivated in this class and don't want to fail.
Oh, definitely not. I'm actually thinking of going into the science field when I leave, so I feel the need to do well and